Welcome to this clinical video presentation on an approach to stroke in young adults. To be able to apply a systematic approach to evaluating and managing ischemic stroke in young adults, we will cover 4 core objectives. First, we will establish a structured 4-question clinical framework to rapidly guide hyperacute care and prevent treatment delays. Second, we will learn to reliably differentiate true ischemic stroke from common stroke mimics in the emergency setting. Third, we will master the comprehensive head-to-heart diagnostic workup to identify non-atherosclerotic, cardiac, systemic, and sex-specific stroke etiologies. Fourth, we will examine evidence-based secondary prevention strategies tailored to specific stroke mechanisms to prevent future recurrence. So let's start with this brief introduction. While stroke is traditionally viewed as a condition affecting older individuals, adults under 50 years of age actually account for 10 to 15% of all ischemic strokes. More importantly, epidemiologic data reveal a concerning shift over time. While stroke hospitalizations in older populations have been declining, hospitalization rates for young adults are steadily rising. Evaluating young stroke patients presents a unique diagnostic challenge. Compared to older adults, young patients have a much higher prevalence of stroke mimics and a far wider spectrum of non-atherosclerotic causes, ranging from arterial dissections and vasculopathies to cardioembolic sources and rare monogenetic conditions. To navigate the diagnostic and therapeutic complexity of stroke in young adults without delaying hyperacute care, we rely on a systematic 4-question clinical framework. This structured approach centers on 4 fundamental questions that guide our entire clinical decision-making process. First, is this truly a stroke? Second, can or should we treat the stroke right now? Third, what caused the stroke? And fourth, how do we best prevent future strokes from occurring? By systematically answering each of these questions in sequence, we ensure rapid emergency management while laying the groundwork for precise etiologic diagnosis and long-term protection. The first question we ask in acute care is whether this presentation is truly a stroke. Our primary, obligatory, and rapidly implementable step is a non-contrast brain CT to reliably distinguish hemorrhagic stroke from ischemic stroke. Simultaneously, we must carefully evaluate for stroke mimics. Young adults have a higher preponderance of mimics compared to older populations, including toxic or metabolic disorders such as hypoglycemia and uremia, brain tumors, infections like meningioencephalitis, migraines, seizures, demyelinating disorders, and psychological conditions. Brain MRI is highly effective at differentiating a true ischemic stroke from these mimic conditions. However, because time is brain in hyperacute care, clinicians must err on the side of treatment. Unless we are absolutely certain that a patient is presenting with a stroke mimic, the rule is to proceed with hyperacute thrombolytic therapy, as the risk of intracerebral hemorrhage in patients given thrombolytics who turn out to have a mimic is very low, at approximately 0.4%. Our second question asks whether we can or should treat the stroke right now. For intravenous thrombolysis with alteplase, the standard treatment window is up to 4.5 hours from last known well, but modern perfusion imaging allows for expanded eligibility up to 24 hours in selected patients. Similarly, for endovascular mechanical thrombectomy in large vessel occlusion, landmark trials like DAWN and DIFFUSE-3 have expanded the treatment window from the standard 6 hours up to 24 hours. Beyond reperfusion, we must manage surgical emergencies. Malignant cerebral edema from large hemispheric middle cerebral artery infarcts requires a decompressive hemicraniectomy performed within 48 hours to reduce poor outcomes and case fatality in young patients. Malignant cerebellar edema carries a high risk of rapid deterioration, acute obstructive hydrocephalus, and brainstem compression, demanding emergent surgical posterior fossa decompression. For specific etiologies, primary or secondary CNS vasculitis is managed acutely with high-dose steroids, intravenous immunoglobulin, or plasma exchange, while refractory moyamoya disease may require surgical revascularization, and sickle cell disease in pediatric patients requires exchange transfusion. Our third question seeks to determine what caused the stroke. Identifying the exact etiology is critical because it directly dictates prognosis, recurrence risk, and secondary prevention. We evaluate the head and brain through clinical localization and neuroimaging. Cortical signs, such as aphasia, neglect, gaze deviation, or visual field deficits, point toward an embolic source, whereas lacunar syndromes suggest small vessel disease. On MRI, cortical infarcts across multiple vascular territories suggest a proximal vessel or cardioembolic source, while distinct patterns can reveal rare conditions such as CADASIL. Moving down, an initial non-invasive vascular evaluation from the skull vertex to the aortic arch using CTA or contrast-enhanced MRA helps us identify arteriopathies. Cervicocerebral arterial dissection accounts for 10 to 25% of young ischemic strokes, most commonly affecting the vertebral arteries, where MRA with T1 fat saturation can reveal a pathognomonic crescentic wall hematoma. Fibromuscular dysplasia typically affects young women with refractory hypertension and demonstrates a string of beads or stack of coins appearance. Large artery atherosclerosis accounts for less than 10% of young strokes overall, though its incidence rises after age 35. Moyamoya shows a puff of smoke angiographic pattern. Inflammatory vasculopathies, including infectious vasculitis from syphilis, tuberculosis, HIV or varicella zoster virus, as well as secondary CNS vasculitis, primary CNS vasculitis, and Susac syndrome, require comprehensive evaluation including lumbar puncture and black blood vessel wall MRI. Cerebral venous sinus thrombosis causes non-arterial territory infarcts or hemorrhages in young women and is evaluated via CT or MR venography. Looking at the heart, cardioembolic sources account for approximately 20% of young strokes. Electrocardiogram and inpatient telemetry are standard, while transthoracic echocardiography with a bubble study is high yield for detecting patent foramen ovale, which is found in up to 50% of young stroke patients. Transesophageal echocardiography alters management in nearly 17% of cases by identifying valvular lesions, endocarditis, or aortic arch atheromas. When evaluating young stroke patients, investigating systemic, blood-borne, and etiological risk factors is essential to uncovering non-atherosclerotic mechanisms. First, we consider traditional risk factors and toxicology screens. Traditional cardiovascular risk factors remain highly prevalent even in younger cohorts. Hyperlipidemia is present in 60% of cases, smoking in 44%, and hypertension in 39%. Furthermore, admission urine toxicology screening is essential to identify illicit substance use, such as cocaine, which carries a 6-fold increased stroke risk, amphetamines, or intravenous drug use, which significantly elevates the risk for infective endocarditis. Second, we evaluate hormonal and sex-specific factors. Migraine with aura independently doubles stroke risk in women. However, when migraine with aura is combined with cigarette smoking and oral contraceptive pills, it creates a dangerous synergy, conferring a 30-fold increased stroke risk in women. Third, we approach hypercoagulable testing judiciously. Routine screening for inherited thrombophilias, such as factor V Leiden, is not recommended for routine arterial ischemic stroke. Instead, inherited panels are strictly reserved for cerebral venous sinus thrombosis or paradoxical embolism via a patent foramen ovale.
Conversely, testing for acquired thrombophilias, particularly antiphospholipid antibody syndrome, remains a key consideration in the systemic workup. Fourth, we assess malignancy and infections. Occult cancer is present in approximately 7% of young stroke cases. Additionally, recent systemic or localized infections, such as respiratory infections within 4 weeks, periodontitis, or COVID-19, can elevate acute stroke risk by predisposing patients to large vessel occlusions. Finally, we look for monogenetic stroke disorders. Single gene conditions such as CADASIL or Fabry disease account for 1 to 7% of young strokes. These inherited arteriopathies should be strongly suspected when there is a positive multi-generational family history, multi-organ clinical involvement, or characteristic MRI patterns.
Finally, our fourth question asks how we can best prevent future strokes from occurring. Young stroke patients face a 9.4% 5-year stroke recurrence risk, making secondary prevention essential. Dual antiplatelet therapy with aspirin and clopidogrel is indicated for 21 days in high-risk TIA and minor stroke, and extended to 90 days for symptomatic intracranial atherosclerosis. Therapeutic anticoagulation is indicated for atrial fibrillation, cerebral venous sinus thrombosis, and antiphospholipid antibody syndrome, though empiric anticoagulation in embolic stroke of undetermined source is not recommended. Aggressive vascular management requires high-intensity statin therapy targeting an LDL below 70 milligrams per deciliter, strict blood pressure control, diabetes management targeting a hemoglobin A1C below 7%, and mandatory cessation of smoking, alcohol, and recreational drugs. When appropriate, procedural interventions such as carotid revascularization or percutaneous patent foramen ovale closure provide crucial protection. By approaching young stroke systematically, confirming diagnosis, acting swiftly, uncovering etiology, and optimizing long-term prevention, we can safeguard our patients' futures and deliver the highest standard of care. Now, we will focus on stroke in young women, because when evaluating stroke in young women, we must recognize the unique interplay of hormonal, gestational, and sex-specific risk factors. A critical clinical concept is the dangerous combination of migraine with aura, oral contraceptive use, and cigarette smoking. While migraine with aura independently doubles stroke risk, combining combined estrogen-progesterone contraceptives and smoking with a history of aura creates a dramatic 30-fold increase in stroke risk. Clinicians must proactively identify this tetrad, counsel on smoking cessation, and recommend non-hormonal or progestin-only contraceptive alternatives. Young women are also disproportionately affected by cerebral venous sinus thrombosis, which accounts for non-arterial territory infarcts or hemorrhages. Oral contraceptive use increases CVST risk up to 16-fold, and when combined with an underlying hereditary thrombophilia, this risk exerts a massive synergistic effect. Pregnancy and the peripartum period represent another high-risk window, where physiological hypercoagulability peaks during the 3rd trimester and the first 12 weeks postpartum. Key mechanisms in this setting include eclampsia, peripartum cardiomyopathy, amniotic fluid embolism, venous thrombosis, and reversible cerebral vasoconstriction syndrome. RCVS, characterized by recurrent thunderclap headaches, is predominantly diagnosed in women aged 20 to 50 and is closely tied to postpartum hormonal shifts, contraceptive adjustments, or vasoactive substance exposures. Finally, non-atherosclerotic arteriopathies like fibromuscular dysplasia show a strong female predominance, classically presenting in young women with refractory hypertension and demonstrating a pathognomonic string of beads appearance on vascular imaging. Recognizing these female-specific mechanisms allows for prompt diagnosis and targeted management. Inflammatory vasculopathies occur when the walls of blood vessels become inflamed, leading to ischemic strokes via thrombosis or severe vasoconstriction. They represent an important category of non-atherosclerotic vasculopathies in young adults. When examining classification and underlying etiologies, we begin with infectious vasculitis, which is a secondary CNS vasculitis. In young stroke patients, inflammatory vasculopathies are most often infectious. Common culprits include syphilis, tuberculosis, human immunodeficiency virus, varicella zoster virus, as well as bacterial and fungal infections. Rarely, Lemierre syndrome, internal jugular vein thrombosis originating from an oropharyngeal infection, can spread inflammation to the nearby internal carotid artery, causing a focal vasculitis and ipsilateral embolic infarcts. Next, we evaluate non-infectious secondary CNS vasculitis, which is driven by systemic inflammatory and autoimmune conditions. Key underlying causes include systemic lupus erythematosus, Behçet syndrome, granulomatosis with polyangiitis, microscopic polyangiitis, rheumatoid arthritis, and sarcoidosis. Third, we consider primary CNS vasculitis, or PACNS. This is diagnosed when vasculitis strictly affects the brain and spinal cord vasculature without any evidence of an underlying systemic inflammatory disorder. Finally, we recognize Susac syndrome, a unique autoimmune-mediated endotheliopathy characterized by a classic clinical triad: encephalopathy, branch retinal artery occlusion, and inner ear disease causing hearing loss. Pathognomonic brain MRI findings in Susac syndrome show central snowball lesions affecting the corpus callosum. When conducting a comprehensive diagnostic workup for ischemic stroke in young adults, we utilize an aggressive multimodal testing strategy to rapidly confirm the stroke, identify non-atherosclerotic mechanisms, and prevent secondary recurrence. First, brain imaging provides immediate confirmation of the stroke subtype and infarct pattern. A non-contrast brain CT or brain MRI is obligatory for urgent confirmation of stroke and exclusion of intracranial hemorrhage, with MRI diffusion-weighted imaging offering superior sensitivity for acute ischemia and small infarcts. Adding MRI DWI with flare assessment helps identify wake-up or unknown onset strokes that may still remain eligible for acute reperfusion strategies. Furthermore, CT perfusion or MR perfusion defines the infarct core versus potentially salvageable ischemic tissue, directly supporting patient selection for reperfusion therapies in extended time windows up to 24 hours. Second, neurovascular imaging identifies large artery disease and non-atherosclerotic vasculopathies. CTA or MRA of the head and neck serves as a primary non-invasive modality to evaluate extracranial and intracranial large vessels, identifying the responsible vascular lesion and confirming large vessel occlusion in thrombectomy candidates. Carotid duplex ultrasonography and transcranial Doppler offer non-invasive alternatives when CTA or MRA is contraindicated or unavailable. When arterial dissection is suspected, a fat-saturated T1 MRI detects intramural hematomas in vessels that might appear structurally normal on routine CTA or MRA. Catheter angiography remains the gold standard for defining subtle non-atherosclerotic vasculopathies or resolving inconclusive non-invasive studies. Additionally, MRI with MR venography represents the most sensitive test for cerebral venous sinus thrombosis and should be obtained urgently when clinical features raise concern for venous occlusion. Third, cardiac rhythm evaluation detects atrial fibrillation and paroxysmal arrhythmias. A 12-lead ECG paired with continuous cardiac monitoring for at least the first 24 hours is standard to detect atrial fibrillation or flutter, while simultaneously evaluating for concomitant acute cardiac ischemia. In cryptogenic stroke, or TIA, extended ambulatory cardiac monitoring for several weeks significantly increases the detection yield of subclinical atrial fibrillation when initial telemetry is negative. Finally,
Cardiac and aortic structural evaluation isolates potential cardioembolic sources. Echocardiography, using TTE or TEE, evaluates for cardioaortic embolic sources. While transthoracic echocardiography is often first-line, transesophageal echocardiography is preferred initially in patients under 45 without known cardiovascular disease, or when TTE is non-diagnostic in embolic-appearing cryptogenic stroke. Advanced cardiac imaging with cardiac MRI or cardiac CT or CTA further identifies embolic sources that may be missed on echocardiography, such as left ventricular thrombi, left ventricular non-compaction, or complex aortic arch atheromas.
Fifth, immediate basic laboratory testing guarantees safety for acute therapies while ruling out stroke mimics. A fingerstick glucose is the only mandatory laboratory test required prior to IV thrombolysis, quickly identifying hypoglycemia as a mimic. Additional acute labs include a complete blood count with platelets to detect thrombocytopenia, PT, INR, and APTT to assess coagulopathy and hemorrhage risk, troponin to detect concomitant myocardial injury, and comprehensive metabolic panels to evaluate organ function and support safe contrast administration. Admission toxicology screening and blood alcohol levels are indicated when substance use could contribute to stroke pathogenesis, and a pregnancy test is routinely obtained in women of childbearing potential. Sixth, targeted etiologic blood testing in young or cryptogenic stroke helps uncover rare systemic mechanisms. Antiphospholipid antibody testing evaluates for antiphospholipid syndrome, particularly in young patients with cryptogenic events or underlying autoimmune history. Vasculitis screening labs, including ESR, CRP, ANA, ANCA, complement levels, and cryoglobulins, are targeted when systemic or constitutional symptoms suggest inflammatory vessel disease. Additionally, hypercoagulability evaluations, such as D-dimer and occult malignancy workups, are considered in cryptogenic cerebral ischemia to identify cancer-associated thrombosis. Finally, when a patent foramen ovale is found or strongly suspected, a dedicated paradoxical embolism pathway is activated. Agitated saline contrast echocardiography or bubble study, combined with transcranial Doppler, identifies and characterizes right-to-left shunting across a PFO, atrial septal defect, or intrapulmonary shunt. Lower extremity venous Doppler searches for deep vein thrombosis as the source of embolism, while a hypercoagulable evaluation excludes underlying clotting disorders that would dictate long-term anticoagulation over percutaneous PFO closure. Through this coordinated approach, we ensure a definitive, mechanism-driven workup tailored to the young stroke patient.